The BirthCircle podcast features experts in all the nuanced areas of pregnancy, birth, and postpartum with the aim of helping women make the choices that will keep them safe, healthy, and empowered. We respect all birth choices and believe in supporting informed consent and evidence-based practices. Nothing said on this podcast should be taken as medical advice. You should always seek the advice of a competent professional for your care. Welcome to the BirthCircle podcast.
This is Sarah with BirthCircle, and today I'm joined with Jennifer Krebs. And Jennifer is a hospital CNM, Certified Nurse Midwife here in Utah. And so my favorite question to ask you crazies, how many hours of sleep did you get last night?
Actually, last night was really good. I told you when we scheduled this that I was going to be on call the day before. So I may be really tired and, somewhere in between that and hopped up on a lot of coffee to try to be here. But actually last night was kind of mellow. I feel like I got 6 hours of sleep.
How do you do that? How do you go on? Because how long are your call schedules?
So my call shifts usually are about 24 hours.
Yeah. Okay. So if you're delivering babies straight for 24 hours, then you come home. How do you
Well, so this year is magical for me because this year all of my children are in school full time.
Oh, you hit the magic
I know,
year.
right? Last year was kind of a tease because kindergarten is only half day.
Yeah.
And it's like you drop your child off at school and then you get to sleep for 2 hours and then you have to go back and get them, so it's a little bit of a tease. So no, right now, I'm fine. I'm totally fine.
Say no more. Those first couple of days after those kids went, to school, the kindergartner, first grade. But it's I don't know what to do with myself. I have thoughts in my head. I can almost finish a thought in my head.
But if you would have talked to me when, my last baby was 8 months old and was still not sleeping through the night.
Yeah.
And I was, had my little, pump that I brought with me to the hospital. And then I'd get home, and get an hour of sleep. And then my baby would wake up and I'd go and nurse. And then, I'd go back to sleep. And then 30 minutes later, the hospital would call. And then I'd go back in, I probably consumed a lot of caffeine during that time.
That's probably why your baby didn't sleep, honestly.
Yeah, well, it might have been.
I have so much admiration and respect for midwives because of the sacrifices you make for your job.
We are known as tired people.
Tired people.
Yeah.
My friend says, I was just born tired. So midwifery is a normal
It's the thing for me.
Thing. Now, me and my sleep, we're serious.
Yeah.
We have a serious relationship. So how did you get into midwifery? Because nobody would want to choose this in their right mind, right?
Well, you don't make it for very long as a midwife unless it's something that you feel very passionate about.
Mm-hmm.
And, I recently noticed that, so I've delivered, I'm somewhere I haven't looked recently, I keep track. I've attended over 1,000 births, so I'm up in the 1,020s or something. And last night I got to be with two women, two first-time moms while they birthed, and I realized how exciting it was still for me, after 1,000 babies. And I thought, that's how you know. That's how you know that you've done the thing that you were meant to do, because you're exhausted and, my house is probably not as clean as other people's.
No judgment.
But it's still that exciting to me every time. So initially, and I was talking about this outside, initially I actually studied anthropology. So I have a degree in development or economic anthropology, and I kind of school hopped. I went to any university that would give me credits for traveling, and I spent.
Sounds like a great plan,
right? It was amazing. It also wasn't super smart. I would be devastated if my children did this to me.
Oh, okay.
Because I left by myself at age 21 for India, rural India.
Well, this is back when, we're not that old, but we're old enough to not have cell phones back when we were 21.
Yeah, no, there were no cell phones. And in fact, I didn't have internet service a lot of the time. And, at one point I got on a bus. I was traveling with a local micro-lending program, a very grassroots program up into the nomadic regions of the northern Himalayas of India. And I remember calling my mom and saying, I'm not going to have a phone or the internet for the next week. If you don't hear from me by Sunday,
maybe
contact the embassy.
Gosh. You're right. You hope your children.
My children, they can never do this to me. Anyway, so I worked. I've always been very passionate about women's issues and working with women. And what I mostly studied were women's issues in poverty. And worked with, I spent some time with the Tibetan Women's Association, working with and collecting oral life histories of Tibetan refugees
Wow.
who are ex-political prisoners from China, working in, very, very poor rural communities. I look back on it now and I feel like so naive, like,
Yeah.
I had no idea what I was doing. But that's, I knew that I would always feel very passionate about that. But I did feel rather helpless. I felt like I didn't have a useful skill. Data collection didn't feel useful in any way to the women that I was working with. And it also, my degree, while it was super interesting and while it made for really great conversation, it didn't qualify me to do much for a living at home. We joked, I was qualified to wait tables with all the history and English majors.
Yeah.
After that.
Dear.
So I wanted a useful skill and I wanted to work with women. And a lot of times in these very, very rural communities, then when you're working with micro-lending programs, the first person that you make contact with are the traditional midwives that already have an established relationship with the community. And I loved that. I loved that midwives were a trusted person
Yeah,
in
I was going to say
communities.
that's probably a lot different than our culture,
Mhm.
and the midwives are kind of the matriarchs. They
Mhm.
hold the community together, right?
Yeah, I mean, for the entire community.
Right. Because
And
they also act sometimes as doctors in those
Mhm.
areas, right?
Yeah. So it was a trusted title. It translated well across cultures. And I didn't even realize that, at the time that there were midwives back home.
Oh,
And my sister-in-law told me about her birth, and she delivers in a hospital, and she wants to be induced, and she wants an epidural,
uh-huh.
and she loves her midwife. And the more I looked into it, I thought, this is what I need. This is exactly
Wow,
what I need.
cool.
So I came back and went into nursing and got my master's in nursing as
Then
a nurse
jumped right
midwife.
in.
Mhm. And it fit so well with everything that I had been passionate about up until then. Um, advocating for women, knowing what kinds of issues and struggles that women were specifically having.
Yeah. So how do you specifically practice? What are the things how do you treat your clients?
Hmm. It's a very broad question. I think, on a daily, and working in the setting that I do, it's a very busy setting. But one of the things I always want my patients to feel is that they're cared for, that I'm somebody that cares about them as a person. They're not a diagnosis. They're not, a dollar sign. They're not. They're people that I care about. I'm deeply involved in their lives, and I know, they maybe come to me with the complaint of, a vaginal infection or depression or anxiety, but there are other things going on in their life that are contributing to whatever situation that they're coming in to see me for.
And even little things like during a birth, I've gotten to witness you a couple of times at births, and you'll do little things like, um, she's having a harder time, and you'll stay by her side a little longer than I've seen other providers, just to kind of
Yeah, I like to kind of assess the need. Some women like to be left alone
yeah,
and for it to have me there like constantly watching over them, even though I really want, I want to be there. I want to do things for you. But for some women, they're
it
like,
makes them nervous to
listen,
have
I
you.
need to be alone right now. They will all
Oh,
reach a point where they need a little
yeah,
something.
yeah.
So I just kind of stay close. So when I see that, I'm there to jump in. But one of the things, and I think you mentioned this before, one of the things I really like to do when I first establish that relationship, once somebody's there in labor, once they're there during that, at the same time powerful and vulnerable time
Mhm.
in labor, is to make sure they realize that I'm there in a service role. I like to make sure everybody has a beverage. Can I get somebody some water? It's 4 a.m. What's your caffeine of choice? Do you need coffee? Do you need a
Yeah.
Diet Coke? What do you need? Does everybody have a pillow and a blanket?
So you're midwifing the whole family.
Yeah, well, it's a family process.
Yeah.
This isn't a mother that's doing this on her own. There's always multiple people involved
Mhm.
in the birth and this new child that's coming into the world. So while at certain times, things may get crazy and suddenly I have to turn into an authority figure, in the room. At times, my most basic role is one of service. This is
Well, it's probably easier to switch into the authoritative role if you've built that level of trust, right?
yeah, yeah, sure. The woman has to feel safe in birth
Yeah.
and labor. And it's easier to feel safe when you know somebody's there to meet your most basic needs, to dim the lights, to make sure you've got your music playing, to make sure your family's comfortable. Because a lot of these women, they're mothers. They want to take care of everybody. And, if you're there to kind of fulfill that role, a lot of them will bring children too.
Yeah,
I'm
yeah.
there to make sure the kids have snacks and that we've got a
A
movie
working
playing for
Wi-Fi
them.
connection for the
Yeah,
the
right,
iPad.
right. We've got the password.
Yeah.
So it's the first really basic kind of mood setter.
So, I don't know how to phrase this question, but how do you differentiate between how you practice and hospital policy? And sometimes, if is there ever like a conflict between how you practice and hospital? Because I guess what I'm getting at is so many women, they connect with their provider and then they go to
Hmm.
the hospital and they find out they can't do certain things that the provider said they could because it's against hospital policy. So how does your work with the hospital, what is that relationship?
I guess I don't really run into that much. A lot of it is because things have changed so much. Hospitals. I mean, this is a service industry. The basic economic principles of supply and demand apply.
Mm.
Women have demanded certain things about their care. Women, there was this huge increase in home birth, and the hospitals responded by saying, well, okay, if women want, skin to skin, they don't want, immediate infant interventions immediately after birth. Let's look at that and see what we can safely provide. And it turns out a lot of almost everything that women want is something we can safely provide in a hospital setting.
Mhm.
So most of my patients come to me, and usually we've worked this out before birth. I almost never run into a situation where somebody's in labor and I'm like blindsided by this desire that they have that I can't meet in the setting that we're
Mm.
at.
Mhm.
We encourage them to come every visit with a list of questions. We encourage them to take classes. We encourage them to get doulas. We encourage, so that as they go through this process of learning and preparing for birth, any of these questions that come up during that process can be brought up during their prenatal care. So I very, very rarely run into a situation where we haven't already talked about their desires and their plans and put big notes in their chart.
So you work in a group practice, but your
I do.
clients do get to know you and the other midwives, whoever's on
Hmm.
call. So
Yeah, we do. I feel like we work in an unusually large practice too.
mhm.
So it's this thing that we constantly worry about as a practice, making sure that our patients feel like they know us and they know how we practice and they feel safe and
Wow. So, like, you
cared
don't
for in
half the
that
practice that are
environment.
kind of blacklisted on social media, and the other half are like,
Yeah, no,
you guys are all pretty
we really try
equally,
not to do
yeah,
that.
try to be united. I've seen that a
Try to
lot.
be really
Go with
careful
that
about
practice, but stay away from
stay
that
away from
one
this
crazy.
person. Yeah,
Yeah.
no. And I know I get really attached to my patients, and you're awake all night with them and you're putting counter pressure on the hips and
Yeah.
you're talking with the
Yeah.
family and you want to be there for the birth, but at a certain point it's like probably not safe. I've been awake for
Probably not
24
safe.
hours, like my partner comes on and I really should leave. But I work with women that I always feel comfortable leaving my patients with, that I care about so much, that I've become so attached to, and knowing that they're going to get the best care possible.
Wow.
These are the women that took care of me through my pregnancy and my birth.
Mhm.
So,
That sounds
so I
like a
do
very
work in a cesarean. Yes, yeah.
sustainable practice that you're not gonna have a lot of turnover, your moms are gonna feel safe, you're gonna have a lot of repeat
I feel
clients.
so lucky to work with the women that I do and the doctors that I do, where I feel so safe. I have no desire to go anywhere. I feel respected. I feel safe. I feel like my
Yeah.
patients are always in good
So
hands.
you work with a group practice of
Hmm.
midwives, and then
Yeah.
you are, how do you say it, overseen by a doctor? Like,
Um,
how he
we
backs you up, or how
They're our backup, and we
they're your backup?
co-manage.
Co-manage.
Yeah, so our patients are midwife patients, unless they become high risk in some way, and then we co-manage. And every now and again, I get somebody that's like becomes so high risk, I feel really uncomfortable taking care of them, and I tell them, you know what, I am happy to be there. I will hold your hand. But at this point, I really need to introduce you to some of my doctors.
Okay. And the doctor's in the hospital and
Mhm.
they have your back at all times.
Yeah, so for my
So
VBAC patients, or for any of my patients that become high risk, they develop preeclampsia or hypertension or any number of complications that can occur. Even if my patients don't see them, I am at a minimum consulting with them. We're in constant communication with each other while we're on call. Telling them when I'm admitting somebody,
she makes
when
the
I'm
texting sign. So you're texting your
I'm
doctors.
texting. Yes, we text. We have a HIPAA compliant text system. I always have to explain to people, like, when you hear anyway, when you hear this, I am not social texting. I do not social text.
I'm not
So
Instagramming
they're
your birth
my
story.
yeah, right.
Ouch.
So they're our backup, but we also have kind of a mutually beneficial relationship with them where we are all surgical first assist. So we help them with all their C-sections.
Oh, so you
So
actually get to go back in with your
yeah,
client.
so it's a way that it also improves their life,
Wow, for sure, because they're not being handed off to somebody they've never met.
So in that way, my clients or patients that do end up needing operative intervention, I don't hand them off to some doctor they've never met. I'm with them. I assist in the procedure. I can talk to them the entire time. I maintain their care afterwards. I mean, obviously, once they've become a surgical patient, my doctors are seeing them and writing their orders. But I still go and see them on a social basis. All of us do. So it's really good for that continuity of care. And for the doctors that I work with, if we're on call and they have to do an emergency C-section, they don't have to wake up one of their partners. I come in and I do that with them. So not only am I benefiting from, them as my backup in the event of an emergency, but, I can also assist them and kind of improve the number of hours that they are woken up during the night.
Wow, which means that they can care for more healthily and happily more clients, more high-risk clients.
Yeah.
This sounds absolutely dreamy.
I love it. I love it. I love that I can provide midwife-style care for even women who become high risk.
Yeah.
There's very, very little that can happen that totally excludes you from midwife care.
I do still feel like you are in this little special bubble that not everybody gets to practice like you do.
That might be true. I don't know.
I think it's true.
Is it true?
Yeah, I think it's pretty true.
I'm very lucky. I'm not going
You're
anywhere.
lucky. But so what kind of questions can a client ask when they're interviewing a midwife or an OB to kind of try and draw out if that group, because here's the thing. What I hear you saying is that the mom is the absolute safest she can be because she's got you and then your continuity of care, because that's a big thing. When you notice a blip on the radar, you're more likely to notice it because you've seen her so much and your partners all practice similarly. So then when you hand her to the doctor, you've got that, you go with her to the OR. It sounds like she's very safe.
Yeah,
Body and mind.
The doctors and I know each other. We work together very closely. I sit next to them in the office all day, so we have a very close relationship. They know how I practice. I know how they practice.
Yeah. And so what are these probing questions that a mom could ask to see if the practice is going to treat her similarly?
Yeah. So, I feel like it's important for women because I feel like, especially first time moms who come into pregnancy and, this whole experience don't know exactly what they want. It's important to educate yourself, to get lots of good quality information and to really know what it is you want out of the experience. And then to make sure you ask all those questions, you present those ideas to your care provider, and, your care provider should at number one, be willing to sit and listen to those. And that might be kind of rare, sit and listen to everything it is you want out of your birth, and out of the experience, and bring lists of specifics. Sometimes when somebody comes to interview me, it's a very short visit because they say, well, I brought my birth plan and, my doctor didn't really like it. And I say, okay, well, let's talk about your birth plan, because what I usually see on those is very standard practice for us. For a woman who's low risk in spontaneous labor, we automatically use intermittent monitoring. We encourage the movement in labor. We have birth balls and we have squat bars and we have peanut balls.
Yeah.
And we use the tubs, and we have waterproof portable monitors that can go in the tub. And if you need antibiotics in labor, there's no reason we can't do that in the tub. Attach your IV to the pole and run your antibiotics in and then detach it.
What a concept.
Yeah, and who knew?
Who knew?
Right? There's no reason you can't push a baby out on your hands and knees, or laying on your side. We immediately, it's our hospital policy is to do skin to skin contact. Even when we invite nursery and respiratory, their goal is to keep a baby on a mother's chest, skin to skin, as much as possible. And if they're working
Wow.
on a baby and the baby's still kind of grunty, you'll hear them say, let's put the baby on mama's chest for a minute and see if we transition a little bit better. And if not, we should do something about this. I must be really lucky because I work in an environment where I'm so confident in everybody that I work with that when, the people I work with say, I'm a little bit more concerned about this baby. I think, oh man, they're concerned. I better look closely.
Yeah.
But
I love that, because to me, this sounds like a great shift in the last 20 years in the culture, not just, maybe it's just your little pocket culture, but it can't just be you.
It can't be.
And so that gets me excited that this is spreading. This type of care is spreading. Like you said, it's
I feel like there's
market.
been a continuous women's empowerment movement, and we don't live in the medical culture that we used to. I talked to one of our nurses over at the hospital who's been around for a long time. I think she's like the longest standing employee at the hospital. And she remembers a time when, she wore a skirt as a nurse and she wore a hat. And when a doctor came on the unit, she was required to stand up and offer him her chair.
Oh my goodness.
And,
Things have changed.
Yeah, it has changed. It's an environment where we realize that as medical providers, we provide a service. We are in the service industry, and that our patients have desires and they have preferences. And, we have training, and we, want to use our expertise, obviously, and we use medical evidence, but that there's a way to incorporate that into the care that we give, to also improve the way people feel about their care, because that's just as important as, their lab results and, your statistical outcomes.
Yeah. And it seems like it makes your lives easier in the end too. If you have this smooth process, then you're not as stressed, but in your team, and everybody wins. Wow. Okay, so tell me how you distinguish in your clients between pain and suffering.
Yeah, this is a big one for me. Especially because we work in a hospital setting and there are, really good anesthesia options available. And, I feel like in our setting, probably about half of my patients really want an unmedicated birth, and they really want somebody who's going to support them through that. And then some of my patients really want an epidural.
I just want to tangent really fast.
Yeah.
Why do you think so many women want vaginal births?
But, for some of them, there's lots of different reasons. For some of them, it's an experience they want. It's a part of motherhood that they want to experience. They want to, get the idea of being able to accomplish that is empowering by itself. And for some of them, it's, a medical issue. They feel like they don't trust drugs. They don't trust, and the medications used in anesthesia. They're people who don't go get an ibuprofen when they get a headache. They're trying to use alternative things outside of those I don't know, other standard treatments.
Right.
So it's kind of not their style. It's not the way they live their life. So and then some medical literature that they've read that will suggest that it's beneficial in a lot of ways.
So when a patient comes into you, do they usually tell you, I want unmedicated vaginal, or I want a medicated vaginal?
We've usually established that well before they're in labor.
Very early.
Yeah, and there's notes all over the chart, so the nurses know. Because a lot of times these women will show up, 8 or 9 centimeters and be saying things like,
Give me an
epidural.
off my
I can't
head."
do this anymore.
And
I've had women be like, just cut the baby out. And, the
Yep.
nurse can look at it and be like, well, Jen's not here yet. She wanted to go natural.
So
we're going to
stall.
offer her an alternative at this point.
That's very cool.
So and our midwives have worked at our facilities for a very long time. So all
So
the nurses are very
all the
familiar with
nurses
how
are
we
very
practice.
trained.
And, but there is, and even in women who have only had unmedicated births, who have done it and done it well and are so familiar with this process, sometimes we're in a labor that's different than the rest. There's a social situation that's different. A family member has recently died and they're not emotionally prepared, or they've suddenly become single. Or they're just not ready. They just don't feel, and then those sensations associated with birth become overwhelming. And there's a difference. There's a very real difference, and over the years, it gets a little more obvious. I feel like when somebody's in pain, because they're 8 or 9 centimeters, and they're saying the things in a way that everybody at 8 or 9 centimeters says.
Everybody says them.
Sometimes we just have to have a good cry before we have a baby.
Why is that?
I don't know. They just got to get it out.
Huh?
It happened the other day.
Just a minute. I remember this in my fourth. I remember telling everybody, just a minute, my body's got to cry. And then it was sobbing. And in my head, I'm like, well, this is ridiculous. I don't have time for this. But my body was sobbing. And then I was like, okay, I'm done.
Yeah. It
wasn't
needs
even
to be
emotional
released before you can move on. Yeah. I've even had people like yelling at birth, really vocalizing. And afterwards, this one woman said to me, man, I was loud. It didn't even really hurt. I just felt like the thing to do at the time.
Bring it on.
I loved it.
But how about the people who are like, I'm so sorry.
Everybody. Yeah.
And you're like, you actually didn't say
it
anything.
Was not, what was happening in your head was far more intense than what we saw, I think, because you looked amazing. I hear that all the time.
Why is it that a birthing woman always just looks so beautiful?
Oh, they do.
Her hair is always doing the right thing, and her skin, they always look beautiful, and they feel like a cow. And we're like, no, you're like a goddess.
You look amazing.
You're so amazing.
Oh, so strong. But yeah, I mean, to get back to the suffering, at some point, sometimes it is suffering, and that's not what we're shooting for. It's not the purpose. It doesn't fulfill the purpose of an unmedicated birth. Sometimes, and usually, I'll offer alternatives. We haven't gotten in the tub. Let's try getting in the tub for a little bit. And that just will not sound appealing at all. And so a woman will look at me like, you need to help me. And
then you get to step in
and then we do. And make sure that they feel really good about this decision. So I find that my mothers make really good decisions for themselves and their babies.
Yeah.
And sometimes it's not a decision they initially thought they would make. So I try to make sure that they feel really confident in that.
Because they can change their mind in the middle, right?
Of an epidural?
Well, no.
Of labor. Okay. I see what you're saying.
But they can change their mind, and they can. Oh, I don't want a water birth, and then decide they want, or they think they want a water birth, and then say, nope, never. I don't want to touch a water ever again.
Yeah,
always extremes.
I try to caution people, beforehand. They'll bring in, labor plans. Sometimes they're like, I want to
at 4:45.
Yeah, I want to deliver on my hands and knees, and I think, well, hands and knees might not feel great at that moment. You never know. You never know. Just be ready to roll with whatever feels right at the time, and feel confident in that.
How do you involve the partners in the experience?
Oh, well, sometimes, I mean, they're there and involved, and, you don't have to tell them anything. And sometimes they look a little bit like a deer in a headlight.
Yeah, I was going to say.
Like, I don't know what to do. She seems really uncomfortable, and I don't like when she's uncomfortable. So, just showing them how to give counter pressure. Especially sometimes I'll have, multiple women in labor, at a time. So I'll go into one room and I'll get a woman situated in the tub, and I'll give her partner a cup to pour water over her back, or,
this.
Yeah, this is what you need to do. She's in a hot tub. Here's some ice water. She's going to need some ice water. Here's a rag for her head. Here's a way to give counter pressure. Let her guide you. Things like that. And then I'll go in another room and get a woman situated on her hands and knees, and show the family how to give really good counter pressure, on her hips while she's on her hands and knees. And
you do this for 24 hours straight.
Yeah. Well, sometimes I'm usually able to lay down for a little bit.
Just thinking about it. Yeah. Okay. So what happens if two babies decide to come at the exact same time? Then it becomes like a Hollywood movie, right?
It very rarely happens. But then I call in another midwife.
Oh, because you can wake them up anytime.
Well, we respond at 3 a.m.
Yeah.
We tend to.
I really like driving around town at 3 a.m.
And
That's my
actually,
favorite time to
listening
drive.
to music at 3 a.m. driving around is actually like,
Yeah.
it's really cool.
I really do like my birth driving.
Yeah.
You know, it's just the traffic's clear and you have a, a
Yeah.
direction you're going, and that's cool. So you've never been shuffled between.
I mean, I definitely have. I can usually see it coming when I send out like a text to all my midwives, and I'm like, listen,
We've got
I need somebody on standby, and then call them in.
Do your doctors back you up sometimes?
I mean, sometimes we end up doing that just because crazy stuff happens. A patient will walk in, pushing in the elevator, and I run in and catch a baby and call my doctor and say, just delivered one of your patients.
Yeah.
Or vice versa. But usually not for situations that don't require their expertise.
Got it. Okay, so this is a question I totally didn't prep you for, but I'm just curious if you have an experience with preventing tearing, or if you
Sure.
have certain opinions about that part of the process.
I mean, it's like a big part of our training as midwives.
Yeah.
You
don't routinely cut
episiotomies
anymore.
No, nobody. The doctors don't either. In fact, our hospitals actually give us reports of our episiotomy rates.
And they publicly shame you in the
they're
break
like,
room.
listen, you need to stop this. Yeah. So, midwives, doctors, everybody gets like a report with their C-section rate, their episiotomy rate, because it's one of those things.
Different.
It is really different. So this is part of the way that I think maybe.
So you actually know your C-section rate?
Yeah. Well, I keep track of my own as well.
Interesting.
So yeah, and our midwife practice keeps track of our C-section rate. So we usually are somewhere between like 4% and 7%.
And if you, and it gives you a good guide for how you're practicing, and so you're okay. Sorry.
I even had one of my doctors bring me his episiotomy, report, and was like, "Look at this.
I'm doing such a good job.
I'm just like the midwives."
Oh,
so.
That's awesome. That's the kind of break room banter.
But these are the kinds of things. These are kinds of things that women have raised concerns about.
Yeah.
And like I said, the supply and demand. So women have raised concerns about them. The hospitals are trying to meet this demand for, fewer episiotomies, a lower C-section rate. Partly because that's what women want, and partly because too many C-sections is like a health problem. Rooming in, and we don't do any of those newborn procedures in the birth room anymore. It used to be we gave erythromycin eye ointment and vitamin K shots and all those things, and we do not. Those do not. We call it the golden hour. The first, while that woman is in that birth room.
That has changed drastically.
Yeah, we don't do that anymore.
You'll do them later?
Yeah, we'll do them later.
Mm-hmm.
If it's always a question that's asked. A lot of my patients opt out of a lot of things.
Yeah.
Which we are also used to.
Do you even have a nursery at the hospital where you work?
We do.
Mm-hmm. Still have a nursery.
Yeah.
I've heard some hospitals are getting rid of their nurseries.
Well, there's still a purpose. Those women that have like particularly exhausting, experiences are sometimes like, I've got to sleep.
But it's not a routine for the babies to spend.
No, it's not routine. It is routine to room in. You'd have to specifically ask.
Take my baby.
Yeah, I need a nap. Or unless the baby had problems, obviously we've got NICUs and and all of that.
But not just return. I mean, even just having my first children, it was routine for them to go to the nursery for like 6 to 8 hours after they were born, especially since we were so large. So there was this whole thing about low blood sugar, which I never understood.
Yeah, they do. They worry about that with large babies and small babies, making sure that their blood sugars are good. But they're still, encourage breastfeeding, and we use, human milk in the hospital now.
Yeah, you can have prescribed. You can have donor milk prescribed.
Yeah.
So cool. Okay, so sorry, back to the tearing thing because.
Oh yeah.
Let's talk about that. So, what have you found that prevents or makes your chances of tearing greater?
Perineal massage is something that we use, pretty standardly. We use like a lubricating gel and kind of massage the perineum, the lower part of the vagina that usually is the part that tears during like crowning. And we do a lot of stretching. I'll use like
while she's almost
pushing.
Crowning while she's pushing. What if she doesn't want you to touch?
Oh, well, then you don't. A lot of times when a woman's crowning, there's so much pressure, don't really notice a whole lot of other things. And if a woman says, I don't like that, then, obviously.
But you
Obviously
found
we
that
don't.
that massage really helps.
But most of my patients request anything that I can do to prevent tearing. So,
please, go ahead.
a warm compress,
Mhm.
a perineal massage, at crowning, we'll try to stop and do, have a nice, slow, controlled delivery of the head.
No, I don't tolerate that slow delivery.
No.
Nope.
Some people look at me like, you've got to be kidding me.
I know.
right now."
I remember
but
my husband was like, slow down. You can see in the video, slow down. And I'm like,
Mhm.
no way.
Yeah.
I
But I'm
regretted
surprised
that.
at how many women are like, I don't know, she told me to stop. Okay. And
They can stop?
yeah, women are amazing. Women are really amazing. I mean, sometimes the urge to push
I was
is
gonna say that
too
last
intense.
one had like eject response, and
Mhm.
I asked my midwife afterwards. I was like, I felt like trying to stop a sneeze, like there was no stopping
Mhm.
it, and I didn't feel that with the other babies.
But even then, I can do a lot with flexion of the head. Put some pressure on the top to keep the head flexed. So
Oh,
the smallest
really?
diameter is passing through the vaginal canal at a time. If they're a little deflexed, or nobody listening can hear me do a deflexed.
She's moving her
head
head
away from the microphone.
Okay, but the flex is looking up at you.
Well, deflexed is looking. So we want to keep their head flexed down, their chin to their chest.
Oh, chin to the chest.
So that
they come through
the
like a
smallest
torpedo.
diameter, is coming through.
Oh, face first. That's got to be really comfortable.
Yeah. You mean like a face presentation?
Yeah, for everybody
that's
involved. Have you seen that before?
Yeah. Oh, yeah.
And you're like, hello, little
it's
one.
incredibly rare. And those poor babies, they're not great photo ops right after birth. Usually, and you got to prepare a family for that.
Oh, no. Like, listen, your baby.
Baby's going to be swollen, like maybe a little black and blue. Face presentations are very rare, and it's good, but they're rare.
So you want them to come, and the face, that's how you get the cone head thing. So the cone head thing is because the baby's in the birth canal for so long, and they're
so
little...
the cone head is more severe in first-time moms who labor for a little bit longer and takes a little bit longer to push a baby out, or malpositioned babies whose heads are somewhat side. My last baby came out with a cone head above her right ear. That little stinker. Trying to come out like the widest possible diameter.
Did she have her hand up by her chin too? Because that would have been really convenient.
I don't remember that part.
I hope they got photos of that.
Yeah.
Little stinker bean.
I know.
So do you think the slower descent then is less likely to tear, or
slower descent? Sure, is less likely to tear, and especially for some reason I've had a lot of like really long crowning births lately, but the babies have tolerated it really well, like perfect heart tone throughout. And sometimes we can wait, and sometimes the babies don't tolerate pushing, quite as much, and we think, we should probably speed this up a little bit.
And how do you speed
heart
it
tones
up?
are down? I can usually have a conversation with a mother
And just say,
and just
push
say,
a little harder.
Hey, I'm a little worried right now. The baby's heart tones are down. Baby needs oxygen. We kind of need to get delivered. And usually those moms dig deep. And push baby out really fast. And sometimes they struggle. I had, especially somebody who's, had several babies before. When you have that conversation, it's kind of like done.
Yeah, mom's on board.
But a first timer might struggle a little bit more.
Especially if she's really tired.
And then, that's a situation that I would call a doctor in.
And you never use forceps, right?
I do not. That's an operative vaginal delivery is a doctor thing. And, I let them know if things aren't looking... No, the doctor does vacuums.
Yeah, and you're just like, well, maybe you...
And that, our doctors are so great. They'll usually come in and, apply a vacuum and get the baby right to crowning and then say, all right.
Your turn.
And you're back in.
That's so amazing.
Yeah. I mean, sometimes they're really complicated, and I think you just go ahead. Yeah, I'm fine with that.
Wow.
But, if everything's fine, they like I said, I work in a wonderful place.
Yeah, really supportive.
Yeah, I really do.
So then if a mom does tear, because that's one of the biggest worries that I hear women talking about. It's almost like they're all worried. I mean, who cares about the whole... The thing, they're focused in on this tearing thing, and I'm trying to figure out a way to have a conversation that's just not all scare and just
for women who are particularly nervous and bring it up, antenatally during their visits. I'll talk to them about perineal massage before birth.
And do you think that helps too?
I'm sure it does in some ways. I mean, there's not really any way to do like evidence-based research on that, like what would have happened if they didn't do perineal massage,
Yeah.
So I know of no great studies
Yeah,
that
it's
prove
really
that it's
hard.
effective, but I
And you can
certainly don't
tear with a
think,
small baby and then be fine with the next big baby.
yeah,
Like
yeah.
even birth to birth, it's like not even a woman.
One of the biggest baby I've ever delivered vaginally was just over 11 pounds. And if I remember correctly, she
She did
didn't
not
tear.
tear.
Yeah.
That is your biggest
And I've
baby, huh?
seen tiny, tiny women, just the women that people don't think should deliver vaginally, like push babies out with lacerations. And women you think, it's going to be fine. There's a little bit of a tear. But
Yeah. So then do you do the stitching part?
yeah.
Unless
Unless it's severe, third or fourth degree lacerations. If we tear through the rectal tissue, I like to bring in a surgeon for that.
the fourth degree, that's when
Through the rectum.
that means that the vagina and the rectum are the same thing.
Yeah, at that
Is
point.
that what that means?
Yeah, we like to fix that real good.
I know. I'm like, I just want to mathematically,
Uh-huh.
I just want to know exactly like what that means. It's just,
Yep.
that's a
That's when I
dangerous
call one of my
situation.
wonderful doctors and
Have they
ask them
perform?
to put her back together. Those are pretty rare. Those are very rare.
Yeah. And
Right.
sometimes you can tear up or to the side.
Yeah, labial tears or
Yeah.
up towards the clitoris. Usually, it's one of the few non-emergent reasons that I will talk to a woman about an episiotomy, when all the labia and the up towards the clitoris seems to be stretching so tightly that I think, ooh,
Because you'd much rather
I feel like you'd rather tear down. And I'll talk to him and say, I'm really worried about the extent of these lacerations. I'd like to cut just a small episiotomy just to give it a direction. So that's really one of the only, and that happens very, very rarely too.
Yeah.
But one of the only situations that I would offer like a non-emergent episiotomy.
So, when because I specialize mostly in home births, that's most of my experience. I've been in the hospital, obviously, with you a few times, but most of the time, I find that when I'm at home, I can kind of hear with the mom where she is, almost knowing what her dilation is, without the midwife checking her, just by the noises she's making and what she's saying and how she's moving. But in the hospital, you don't always get that because of epidurals, right? So
Oh yeah.
how does an epidural change the course of like a natural, like kind of outline the difference between a non-medicated birth in terms of like intensity
Cues.
and experience and cues
Mhm.
versus an epidural?
Well, certainly when somebody has an epidural, in order to assure that we're progressing or that we're complete, it does require a couple more vaginal exams. But it depends. It depends on the situation. If I have somebody that gets an epidural really early in labor, it might slow it down a little bit, and we might need some pitocin augmentation or to break water. Whereas somebody who comes in and is in rip-roaring active labor, sometimes they get that epidural and all their pelvic muscles relax and like suddenly they're complete.
So you can go from like a 4 to a 10.
Yeah,
Oh,
like,
we're going to talk about that next,
yeah?
dilation.
Okay,
Yeah.
okay.
But they can just dilate really quickly once
yeah,
the
and
baby
it's
relaxes.
difficult to know without checking a cervix. Sometimes there'll be indications in the baby's heart rate that we're moving kind of fast. Whereas somebody who's unmedicated definitely shows signs. And I'll sit with women and think, man, we're not really vocalizing yet. Like I'm not hearing any moans.
Well, but have you
Like
ever
I
been with
wonder
a
if
woman
we're.
where you thought maybe she was still at a 2 or a 3 and she's at a 10? I mean, do you get
Oh,
confused sometimes?
I have. Yeah, sometimes, and
Or they
I'll have
sound like they're going to
women.
be at a 10 and
Yeah,
you're
they
actually at
sound
a
like
2.
they're ready to push your baby out, and they're like 1 centimeter. Yeah,
And you're like, oh, honey.
been through all of that. But usually in the normal progression of labor, there are certain signs. The beginning is kind of longer, and then once you get to 5 or 6 centimeters, things kind of pick up, and there's some vocalization, and you get to 8 or 9 centimeters, and a woman might question her ability to follow through with this, and then I think,
to be on
oh,
Earth.
fantastic, that means we're almost done.
And do you find that there's a lull? I know with my first, when there was a lull at probably like 9 centimeters, that's transition, that everybody's like, whoa, we got to start the pit. Everybody's, slowing down. How long can that lull last before you're like, what's going on?
I mean, if somebody were, it would depend on like their level of distress too.
Oh, okay.
Where I'm like, this woman needs to be done. this is.
Well, no, but like sometimes
But
you'll get to
but
the lull and
sometimes,
there won't
yeah,
be
it'll be a couple
contraction for like
hours.
20 minutes. And
Oh,
everyone's like, maybe this was all a joke. Maybe you're not actually pregnant.
no, but
Maybe
I've never known anybody to stay pregnant forever. At that point,
sometimes it's like, what's going on here?
it'll always pick up, and if it's taking longer than she wants, we can do something about it. But
Yeah. And then, so the epidural is, I like to think of it as just a really good tool
mhm,
to,
sure.
for mental health.
Yeah. Sometimes it's what a woman wants out of the experience. She wants to
Mhm.
be able to sit around and visit with her family and push a baby out and enjoy the baby and not
Are there
be super
different
tired.
kinds of epidurals that make it so you can feel like, can a woman feel that she's complete?
A lot of times, we don't, at least in our facilities, we don't do epidurals the way I feel like we used to, where we try to eliminate all sensation and like a woman can't move her legs or,
Mm.
it's not
This is
useful in
not
the
the
end when you're
epidurals
trying
of
to
the
push a baby
80s.
out,
Okay.
yeah, and you have
Floppy
no idea
legs.
if you're pushing right or if you're pushing, in a way that's helping you progress at all. Even when anesthesia comes in and talks to our patients, they'll say, "Listen, I want to make you comfortable. You should be able to take a nap, but you're going to feel pressure. And as you get ready to deliver, it's going to be a lot of pressure, and that's good because it's going to help you push. And our ideal epidurals, they can move their legs. It's not always perfect.
Yeah.
Um,
But they can feel that pressure. It's just not
yeah,
any
yeah.
pain, not any.
We get excited about the strangest things at the hospital.
Tell me about
A
it.
woman tells me that she needs to have a bowel movement, and I think, oh, that's great.
Fantastic. Congratulations.
It's not a bowel movement; it's a
It's a
head.
baby. And especially if she has an epidural with that, right?
Yeah.
Because then you're like,
Yeah.
oh, get on the backward scrubs and the cake. I always
Yep.
love it when you guys don your whole like
Our get up,
your your suit, your
gown,
space
and
suit.
gloves.
And it goes on backwards and the
Yep.
gloves. Yeah, I know. Because again, at home birth, you just put
Right.
down a few Chex pads and you're all ready.
And everything's fine.
And then the bed goes the whole transformer thing.
Yep.
Like this magic.
I love that though. I love that I can turn my beds into chairs.
Yeah. Yeah. Well, I loved my hospital bed with the second one because they just
Mhm.
kept moving it to help accommodate my position and
Mhm.
then, just supportive. So, okay. So talk about this elusive dilation thing. First of all, why I remember when I was giving birth the first time, they wanted me to do 1 centimeter per hour. And if I wasn't,
Oh yeah,
they were really bugged.
curve.
The curve.
Yeah,
Is that what it is?
Friedman curve. Yeah, I feel like we've kind of moved on from that. And the literature. And
Yes, but our moms and our mother-in-laws and our aunties, they haven't.
Yeah, they
So,
do. They
yeah.
want that 1 centimeter an hour,
Mhm.
or like.
And if they're in the birthing room with you, they get really nervous.
I'll hear things from women like, oh, I hear you're not supposed to break water until, you're at least 3 centimeters, or I hear you're not supposed to. And I think, well, nothing's quite that rigid.
Yeah.
We're inducing for hypertension. We have to do something.
Yeah.
So yeah, the curve. I haven't even heard that for a while. But it was definitely something we talked about in school. Making sure that we don't fall off the curve. But yeah, all of our professional organizations, ACOG and
They've all changed.
they're recommending that we wait a lot longer and be a lot more patient. It used to be, we only push for 3 hours, and if you're not low enough for an operative vaginal delivery, and now they're saying like you can push longer than that. And if you've stalled for 2 to 3 hours,
And
then
what do
that's
you
an arrest of
define-
labor.
What do you define as pushing? What's the pushing phase?
Completely dilated and actively
And like
bearing
crunching
down. Yeah.
Okay.
So I mean, the recommendation is to be a lot more patient.
What
And
happens if a woman wants to bear down before she's complete? Do you always check?
I mean, if I'm dealing with somebody who's on like baby number 5 or 6, I mean, if they're
I know what I'm doing.
if they're 9 centimeters, like they won't be for long if they're pushing.
They're pushing.
But it's I like to make sure because I'll have some people with urges to push. But this
What's
doesn't
this
have to be very.
elusive lip? Everybody's
lip?
like, I had a lip. I almost died. Everybody almost died, and I'm like, what the heck is a lip
It's
anyway?
just a tiny little bit of cervix, and sometimes it can prevent the head from coming down. Or if you push too soon, that lip can start to swell and become more.
But wouldn't the baby just push it out of the way? I mean, I've seen midwives get up in there and move the lip during a contraction. I'm like, that doesn't look very comfortable.
No, it's not. It is not. So, So, I've had women with urges to bear down at like 6 centimeters, and then you can cause a lot of swelling and
Yeah, and then you end
and
up
things
with
like
the.
that.
Well,
Or
what is she feeling if she feels the urge to push down at 6 centimeters? What is she
just
feeling?
pressure. I mean, sometimes
Oh.
sometimes that head's really low, and
It's like,
it's stimulating that reflex, but the cervix isn't all the way out of the way.
Oh, got it.
So, I mean, it's usually not a problem. I mean, usually women have an urge to push like right as that cervix is disappearing. But I mean, I've had situations where I've done that a couple of times
Have you been
actually.
that mean midwife?
I know,
to
but I
wanna let
usually
that out of the
prepare
way?
them. Where it was one of our office staffs. Anyway, it's a family member, and she was unmedicated, and I put the baby on the monitor, and heart tones were very, very low,
Ooh.
and they were not coming back up. And she was like 8 centimeters, and I thought, we need to deliver. Like, this baby is not doing well. You're gonna really want to kick me in the head for like 10 seconds, but I feel like this is what needs to happen. And I, pushed it back, and we delivered, and the baby did
But you
great.
can't really manually dilate a cervix, right?
No,
Can you
I mean,
force
not,
it open?
I mean, like early.
We're making hand symbols here.
Yeah, I know.
I've heard like people can like
Looking at you.
two fingers that they can put, and they can spread their fingers and open the cervix manually. And I hear these stories, and I'm like,
Like, are they in labor?
is this a trained midwife?
That
Yeah.
sounds really terrible.
No, you would never do that,
I don't
right?
know why you would do that. It's like artificial dilation anyway. It's not like it's,
It's not going to help the baby come out faster, right?
yeah, not in
Interesting.
that scenario.
I hear the craziest things, and I'm like, I don't know what are people thinking?
Yeah, that sounds really terrible.
Oh, okay. So what about monitors, the different types of monitoring what do you like to do, and what are the options for doing?
Yeah, sure. So in somebody who's in spontaneous normal labor, we like to listen to the baby for like 20 to 30 minutes, make sure we see all the signs of well-being. And, all the evidence suggests at that point that intermittent monitoring is perfectly reasonable. So then we listen before, during, and after a contraction or surge, whatever.
Once in a while?
Every 30 minutes.
Every 30 minutes.
And then more frequently during the pushing phase,
Yeah.
during the second phase of labor. We can, like I said, we can do that while you're sitting on a ball, while you're in the tub. Sometimes we put the monitor on and the baby doesn't look very reassuring, or like I said, I like to provide midwife style care for even women who are high risk. So sometimes I'm inducing somebody because they have preeclampsia or cholestasis, or any number of conditions that can come up that would indicate
cholestasis.
Cholestasis. It's a gallbladder issue, intrahepatic cholestasis. And my patients still want as much of that experience as possible. But I have to monitor continuously while we're, inducing and on Pitocin. But I have portable units.
So when they're in Pitocin, they do have to be monitored.
Yeah, I cannot safely administer Pitocin without monitoring a baby.
Because Pitocin can lead to too strong a contraction.
If it's over, yeah, we have very strict rules about how Pitocin can be used and when we can turn it up and by how much, and the kind of monitoring that needs to be done to make sure that we don't induce distress. But I have waterproof units, and I can monitor women continuously in the tub. They can be standing and walk. I can monitor on your hands and knees or while sitting on a ball.
Now, what's the difference between, you're talking about those belly monitors that kind of strap on you?
Yeah, we have a Novi now at one of our hospitals.
What is that?
It's a different monitor. It's like taped on.
Oh, nice. Is it wireless?
Yeah, and it's wireless.
That's so groovy.
Yeah, so it takes a minute to set it up, but
then it's there. What about
nice.
internal monitoring? What's that all about?
So internal monitoring, we don't use quite as often. It requires there's the fetal scalp electrode that attaches, to the first couple of layers of skin on the baby's head, and that's so that we can really accurately monitor a baby's heart rate. And that's something that I would use in an emergency where, we're thinking about doing an operative delivery. I need to know if I need to run back to the OR, and I'm not sure I'm getting mother's heart rate. I'm not sure I'm getting a heart rate accurately. So that's something that I would want to apply in that situation. So I make sure that I'm getting a really accurate assessment of how the baby's doing before we make any major decisions.
Because the external monitor can tell you heart rate, but it can't really tell you Can the scalpel one tell you oxygen content, or can it tell you?
No, I mean, we look for different signs of oxygenation. There are
It's
different
just
signs in the heart rate, the variability. And but sometimes the heart rate will go down and we'll pick up mom's heart rate instead of the baby's. And
that's
it can be
sad.
difficult to distinguish between the two. So it becomes important, especially if we're thinking about, intervening operatively to make sure that we're accurately assessing the baby's heart rate. And those are situations that get a little scarier.
Yeah.
Or, there's difficulty. Yeah, anytime it's difficult to monitor and we're worried.
Are there two different types of internal monitors?
Yes. So the other one is the intrauterine pressure catheter.
Yeah, I was wondering about that.
It's a tube that goes in through the cervix and sits beside the baby. So when we monitor contractions externally, we can monitor when they're happening, but we cannot monitor their strength. And sometimes, depending on the size of the habitus of the patient, they're a little bit more difficult to pick up. If I have a patient, if I'm using Pitocin for a patient that needs that, I have to be able to monitor the frequency of the contractions. I can't be having more than 5 and 10 minutes. That's too much.
Yep.
But if I can't accurately measure the contractions, I can't know if I'm safely using the Pitocin. Or, let's say I've had somebody at 8 centimeters for 7 hours.
But you can't do that if the water's not broken, right?
No, the water has to be broken for both of these.
Both of these,
Mhm.
yeah.
That's a good point. So, I have somebody that's stalled out. We don't know why. And before we say, well, this patient's been 8 centimeters for 7 hours, like we should consider a C-section, I say, let's measure these contractions, and I'll insert that, and we may find that the contractions, now that we can measure them because it's internally, the contractions are totally inadequate. We just need a little extra help. It's not that there's a problem with the pelvis or position of the baby or something like that. We're kind of assessing all the different reasons that something could be going a little bit wrong.
And the whole time you are telling your mom what
Absolutely.
you're doing,
We are talking about it.
She's making choices.
Informed choices. All of there's nothing that we do that a mother can't say, I'm really uncomfortable with that.
Yeah.
And we can talk about that until, even in the very rare scenarios where something is such a severe emergency that I say, we need to go and we need to go now. I'm walking back to the OR and I'm saying, do you understand what's happening now? Do you have any questions? We need to move very quickly. So in most of these other situations, we've got plenty of time to sit around.
So going
chat
all the way
about
to
it.
the scary part, if you have an emergency, then and they haven't we didn't even talk about this, Heplox, or they don't have a continuous IV, then they have to go under general anesthesia, right?
We still need an IV in those
You
situations.
still do? No, but I mean, you always do an IV?
Well, we always, we like to have IVs in place. We certainly have people that opt out of them. But you don't have to be on a continuous infusion.
Got it. And then if they need an emergency, you've got that.
Then we have that in place.
Hardware
that we can
already
use.
hooked up that you can just go in.
Yeah, I mean, using general anesthesia is pretty rare.
Is it?
Yeah.
Just hear these horror stories.
Yeah, horror stories.
But you're saying that most of the time you have time to talk about options.
Most of the time. Even if we're pretty worried. There's a couple minutes that you can sit down and say.
Sit down and get an epidural, go in for C-section. Nobody's losing their
or spinal at that point. Yeah, they're faster.
Wow. Oh my goodness. I could talk to you all day long. And thank you for answering all of my burning questions, because I get so tired of hearing scare stories. I mean, there's truth to them. But
those things happen.
Yeah, but
They're
it's what is actually happening, and the more midwives we have that are like you, that support their women, their clients. Now it's a patient. Home birth, it's a client.
It's a woman.
Yeah, your patients. You support their choices and guide them to be safe.
Yeah,
and healthy,
safe and happy. Have a positive experience. No matter what you choose, whether you want an unmedicated birth with as few people touching you and few medical interventions as possible, humanly possible, or an epidural or a repeat planned C-section, it should be an experience that is memorable and loving and positive and empowering. And there's a way for any woman's desired birth to be that way.
Yeah. Awesome. Thank you so much.
Yeah.
Here
Thanks
today.
for having me.
Please visit us at birthcircle.com, join our Facebook groups, or find us on Instagram and Pinterest. We hope you'll use our resources to support your birthing experience.